Dubinsky, and I'm joined today by Susie Connor from Liverpool Hospital in Sydney. Welcome, Susie.
Thank you, Marla. At this year's DDW at Washington, our group was looking at psychosocial issues and quality of life issues in inflammatory bowel disease patients. And what our group took from the podium to the practice was a number of abstracts. One particularly by Corey Siegel's group at Dartmouth looked at a decision aid, a Crohn's disease decision aid, and a prospect prediction risk tool, and these two tools for patients help them. The decision aid discusses the risks and benefits of treatment, plus also the risks and benefits of not being on treatment and the other things like malignancy, and also looks at the disease course. And the prospect prediction tool individualises that patient's risk and explains to them the patient's risk over time of them either, if they don't go on therapy, and what complications they would potentially have. And so then they had a group of patients who got the decision aid and the prediction tool, and they had a group that had standard of care where patients just talked to their physician as normal. And what they found was in the intervention group, those patients were more likely to decide on combination therapy, less likely to decide on no treatment, and also had a far greater trust in their physicians.
Which is interesting,
Isn't
right?
it? Simply
Yes.
by using these tools which were complementary to the discussion with the physician. That was the first abstract. The second abstract and the third abstract were looking specifically around the importance of addressing psychological issues in inflammatory bowel disease patients. We know depression and anxiety are very common, and this study from Jane Andrews' group in Adelaide, Australia, highlighted the fact that when patients are willing to be screened for mental health illness, in fact 55% of patients in the clinic did have significant mental health illness. And then when those patients then went on to see a psychologist and had either cognitive behavioural therapy or ACT therapy for a year, depending on their need, after a year, so it was a 12-month outcome, they had reduction in anxiety and depression and stress, but as interestingly, they actually also had a reduction in presentations to emergency, reduction in need for the helpline, and reduction in need for calls to the helpline, despite their illness, and also the disease remained well controlled. And the patients also were very keen to continue to have a psychologist in the clinic.
I mean, it speaks to the importance of
having
having a team member in the clinic.
It does. And the other abstract was by the Pittsburgh group looking at an app which is called Lantern. There are a number of different apps available where you can get cognitive behavioural therapy on the app. And they looked at that compared to standard of care, and in patients who used the app, it was only for 3 months, they found again reduction in anxiety and depression. In fact, anxiety was even better controlled with the app. So that's another tool potentially that we can use in the clinic where we don't have the option of a psychologist. The app also had an option to be able to call someone to help if the patient was at need.
Oh, wow. Okay.
Which is fantastic. But again, it highlights again the importance of tools to help with psychological care for our IBD patients.
So I think Susie and her group really highlighted the importance of behavioral health interventions, decision support tools, and lends itself for really a great future for our patients to be able to give them the tools they need to really be successful. Thank you.
Yeah, thank you.